Well, I don't see Jason, but we'll get to turn on anyway. So Dr. Kruger has to attend a meeting, so she's not here. Of course, she's going to miss a very interesting lecture presented by the Division of Endocrinology, Metabolism, and Diabetes. Our previous chair, Dr. Roman, would always introduce the medical grand rounds by presenting a vignette in the history of medicine that occurred during that week. And I always look forward to that. I thought that was interesting. It was casual, and it introduced the session. It was a good idea. I don't want to upstage that. My approach has been, I was a member of the FDA Advisory Committee for Endocrine Drugs some years ago. And when I introduce the grand rounds, I sometimes will just mention a new drug, which has been introduced. And in fact, I introduced the medical grand rounds in March 2013. And it turned out that a new drug was introduced that month, and it was called canagliflozin, or Invokana. And this drug is an SGLT2 inhibitor, and it works by causing glycosuria and lowering glucose in that way. And we're going to hear much more about it. As it turns out, when I was a medical resident, which predated home glucose monitoring and hemoglobin A1C, our goal was to prevent glycosuria. When people had glycosuria, we knew they weren't being treated well. And now we have the opposite. We have a drug which promotes glycosuria. And in fact, this has become a multi-billion-dollar industry. There are now 4 SGLT2 inhibitors and several combinations, and they account for $4 billion sales of drugs in the United States. Our speaker today, Dr. Villafuerte, has been a devotee of diabetes for her entire career. I won't say how many years. And she has run an NIH-funded laboratory which examines insulin action on cells and how insulin regulates gene transcription and cells in proteins produced by the liver. And she's an astute clinician. She takes on the most difficult cases and controls their blood glucose in a way you just can't believe. And she's also a wonderful lecturer. And as it turns out this week, a drug that was released is called Trijardi, and it is a combination of 3 diabetes drugs. It includes a SGLT2 inhibitor, a gliptin, which stimulates insulin secretion, and metformin, which works on insulin resistance and hepatic glucose production, and packages them all into one pill. Obviously a business enterprise, but also maybe a way to get people to take enough medication to keep their glucose down. And with that, I'll introduce Dr. Villafuerte. We look forward to her informative discussion of new glucose-lowering drugs. Thank you, Betty.
Thank you, Dr. Winter, for that kind introduction. Before the GI people complain, I could put the GI people also in the title. This is a common drug for diabetes that is mostly used by internists and general practitioner. Most of the diabetics are managed by internists. Hopefully, at the end of the talk, you'll learn something about the cardiovascular outcome trials on GLP-1 receptor agonists and SGLT2 inhibitors, and know how to use these drugs. For disclosure, I participated in some of the clinical trials to be mentioned in this lecture. In 2015, 30.3 million or 9.4% of Americans have diabetes, and about 23 million are diagnosed cases, and 7.2 million are undiagnosed cases. More worrisome is the number of people with pre-diabetes, meaning they have impaired fasting glucose or impaired glucose tolerance, and it constitutes 34% of the population. 37% of Americans over age 20, or 51% of adults over 65 years old have pre-diabetes. And the conversion rate to diabetes is 5 to 10% every year. But there's also the flip side, 5 to 10% from pre-diabetes became normoglycemic. Although the increased rise in the prevalence of diabetes has slightly tapered off for the past 3 to 4 years, it's still increasing. In 2019, it's estimated that 10.9% of the US population have diabetes. Type 2 diabetes is an independent risk factor for macrovascular disease, as most of the cardiologists here know. In 1979, the Framingham study showed that type 2 diabetes was associated with 2 to 3-fold increase in risk of atherosclerotic cardiovascular disease. That is still true at present.
Okay.
And there's a US database showing that the impact of diabetes is more on heart failure than coronary artery disease. A study of over 65,000 patients with type 2 diabetes who were being treated with insulin, the 6-year hospitalization rate was 243 per 10,000 patients for heart failure and 97 per 10,000 patients for MI. This gives rise to the concept of diabetic cardiomyopathy, which is recognized both by the American College of Cardiology and European Society of Cardiologists, in which there's ventricular dysfunction in the absence of atherosclerotic cardiovascular disease and hypertension. Pathophysiologically, patients will have left ventricular hypertrophy and fibrosis, leading to decreased left ventricular compliance or stiffness, impaired diastolic filling, and eventually systolic dysfunction. Coronary artery disease is responsible for as many as 30% of the deaths in the diabetic population, and more than 2/3 of diabetic patients above the age of 65 will die because of vascular problems. Furthermore, silent ischemia is much more prevalent in diabetic than in non-diabetic, 10 to 20% in diabetic patients compared to 1 to 4% in the general population. There's always this controversy in diabetes treatment. For a long time already, we know that many data show a clear increase of the cardiovascular event risk with worse glycemic control. But the interventional studies, including the use of insulin, did not find a consistent reduction of cardiovascular disease with reduction of glycated hemoglobin. That's because the risk for atherosclerosis in diabetes is much more complicated than glucose control alone. This boils down to what we are using for diabetes treatment. Insulin was discovered in the early 1920s, so it's almost 100 years now. And it was commercialized in 1922. It took another 30 years before sulfonylurea was developed. Then another 30 years or so before metformin and the alpha-glucosidase inhibitors were discovered. And then another 10 years or so before the thiazolidinediones were discovered, followed by the GLP-1 agonists, the DPP-4 inhibitors, and then we have all these SGLT2 inhibitors, and different types of SGLT2 inhibitors, etc. So the problem is in 2007, somebody from Cleveland Clinic published that after 10 years use of rosiglitazone, there's possibility that it increases cardiovascular disease. So in 2008, FDA mandated that all new diabetic drugs that will be developed has to go through cardiovascular outcome trials of at least 18 months. So this end up, we have all of these clinical trials after the FDA mandates. I have encircled the one that our divisions were involved. Dr. Krishnasamy did the SUSTAIN, LEADER, and DEVOTE trial in BA, and we did the LEADER and the VERTIS cardiovascular trial here at HCOC. These are the new drugs that has been developed in the 2000s, the peptidase 4 inhibitors, the glucagon-like peptide 1 receptor agonist, and the sodium glucose cotransporter 2 inhibitors. And these are the commercial names of the drug, which is, you were highly exposed to the advertisement of this drug at dinner time. So, what is the GLP-1 hormone? The GLP-1 hormone are considered as incretin hormones. It is released from the L cells of the distal small intestine and some in the proximal colon. This is the amino acid structure of this hormone, and it has a very short half-life, about 2 minutes only in the circulation. So, how do we know it has something to do with insulin secretion? Normal person, when they eat, they'll have 2 phases of insulin secretion. The first phase occurs within 5 minutes, and the second phase lasts about 25 minutes. In type 2 diabetes, you lose the ability to have that first phase insulin secretion. And in type 1 diabetes, of course, you're essentially flat. You're not producing much insulin from your pancreas. We know that if we give glucose through the intravenous route, what happens is the glucose in the plasma will stimulate insulin secretion from the pancreas, so we have this deep increase in insulin. However, if we give the equivalent amount of glucose per orum, meaning they ingest it, there's a higher insulin secretion compared to when you give it through the IV route. So this difference in insulin secretion is called the incretin effect. And essentially, what happens is when you eat something and the food goes to the small intestine, it will stimulate the L cells to produce GLP-1 or glucagon-like peptide 1, which then go to the pancreas and stimulate insulin secretion. And there's a successive development of multiple generations of GLP-1 agonists. All these drugs were developed with the hormone as a target. Okay. So the exenatide or Byetta came out first. It has about 50% homology to the native GLP-1, and it is immunogenic. It came from the saliva of the Gila monster from New Mexico. So that was the first generation drug, followed by liraglutide, which now has a longer half-life. Instead of the 2.4 hours with exenatide, it now has 13 hours. Now with the exenatide extended release, it's 2 weeks and so forth, until we have the semaglutide, which will last for 2 to 3 weeks. Okay. So the GLP-1 acts by mainly increasing insulin release from the beta cells. It has also other effects, including decreasing glucagon secretion from the pancreas, decreased gluconogenic effect, and it delayed the gastric emptying time, and it promotes satiety and reduces appetite. But we also have the sodium glucose co-transporters inhibitor. So how does this act? It turns out that the kidney is a very important regulator of blood sugar. After overnight fasting, 20% of our glucose came from gluconeogenesis from the kidney. And if you think about how much the glomerulus work is, in general, if the glomerulus filters about 180 liters of plasma per day, and if your average blood sugar is running about 100 milligram per deciliter or 1,000 milligram per liter, it means that your glomerulus has to filter 180 grams of glucose per day. And yet, we do not see much glucosuria in normal people. The reason for that is there's a lot of receptors and in the proximal tubules that reabsorb the glucose. After the filtration from glomerulus, about 90 to 97% of the glucose is reabsorbed through the action of SGLT2. And if the SGLT2 miss something, the SGLT1 will help reabsorb the residual glucose left over by that receptor. And this is about 10% of the reabsorption of glucose. And the mechanism by which reabsorption occurs in the epithelium of the proximal tubule is through by creating the sodium gradient. This is an ATPase-mediated sodium-potassium pump. It will maintain the sodium gradient that will also bring in the glucose. Eventually, the sodium and glucose go back into the interstitial fluid and then go to the circulation again. And for each molecule of sodium, there's also one molecule of glucose that's being reabsorbed for SGLT2. So for SGLT1, there's 2 molecules of sodium that's being absorbed per molecule of glucose. So what you're seeing is there's a concurrent, if you block these receptors, you will lose both the sodium and the glucose, and much more sodium loss with blockade of SGLT1. SGLT1. Okay. So what are the SGLT2 inhibitor compounds that has been developed? It has a long half-life of 10 to 13 hours. It binds to renal tubular transporter for at least 16 to 24 hours. It inhibits 30 to 50% of the glucose reabsorption rate. So in general, if you filter 180 grams per day of glucose, you lose about 90 grams of glucose in the urine. If you have much higher glucose, like in diabetic patients, sometimes you can lose as much as 100 to 150 grams of glucose. In diabetic patients, if you lose glucose of 100 grams per day, you're essentially losing 400 calories per day through your urine. And chronic use of SGLT2 inhibitor compound has been shown to induce body water loss of 300 to 500 ml per day and sodium excretion of 20 to 40 MEq per day. That's not much, actually. It's about 45 to 90 milligrams of sodium per day. So, if you look at these specifics, they generally decrease the A1C by about 1%. Canagliflozin is strong, it's more potent compared to the other SGLT2 inhibitors. They decrease the fasting glucose, postprandial glucose, and the urinary glucose. That you loss is higher with canagliflozin compared to dapagliflozin and empagliflozin. And as a consequence of glucosuria, you have some weight loss and decrease in systolic blood pressure. In terms of selectivity for SGLT2 receptor compared to SGLT1, the most specific for SGLT2 receptor is empagliflozin, yes, and followed by dapagliflozin, then canagliflozin. So canagliflozin tends to block some of the SGLT1 receptor. That's why they have more side effects. Now, to review the statistics, which I'm not good at, just a reminder, because I will be going through some of this. Relative risk is, of course, the ratio of the risk of an event in the exposed group to the risk of event in the unexposed group. So if it's 1, there's no difference between the two groups. Less than 1, the event is less likely to occur in the treated group. Over 1, the event is more likely to occur in the exposed group. The odds ratio is about the same. The only difference is this is applied to a retrospective study, while relative risk is applied to prospective studies. The hazard ratio, by definition, is the probability in which an individual would experience the event at any fixed time point, and the number needed to treat is the number of patients that you need to treat in order to observe the outcome of interest. So the smaller the number to treat, the more effective the treatment is. These are the results of the cardiovascular outcome trial for GLP-1 receptor agonists. And I have put an underline on the ones that are statistically significant. For lixisenatide or adlixin, there was no significant difference in terms of major adverse cardiovascular event. The major adverse cardiovascular event, or MACE, represent cardiovascular death, non-fatal MI, and non-fatal stroke. And the first one that showed positive results was liraglutide or Victoza. The MACE, there was 13% decrease in MACE, and then there was also 13% decrease in hospitalization for heart failure. The semaglutide, which is Ozempic, it's the most potent of this, and as I show you before, it lasts for days, and there was a 26% reduction in MACE, but no effect on congestive heart failure hospitalization. The exenatide, which is the weakest of all these medication, there was a 9% decrease in MACE, and abiglutide, Tansium, has a 22% decrease in MACE. The heart failure part was not determined. Dulaglutide, which I use most, has a 12% decrease in MACE and also 7% decrease in congestive heart failure. These are for the GLP-1 agonists. For the SGLT2 inhibitors, there was also cardiovascular advantage. The empagliflozin, Jardiance, you hear that every dinner time. It's a 14% decrease in MACE and 35% decrease in hospitalization for heart failure. Canagliflozin, 14% decrease in MACE and 33% decrease in hospitalization for congestive heart failure. Dapagliflozin, the decrease in MACE is only 7%, and decreased hospitalization is 27%. Again, in terms of number to treat, you have to treat this number of patients in order to see one good outcome. So it runs between 43 to 61. So how does this compare with medications that are now being used for cardiovascular treatment? Evolocumab or Repatha will give you a hazard ratio and relative risk reduction of 0.85 to 0.86, and the number to treat in order to see one positive result is 63. And this antiplatelet, prasugrel, also has about similar reduction, but this is compared to clopidogrel, which already has some effect. And brilentigagriclor, I don't know why they name all of this in an unpronounceable way, okay, has also a decrease in hazard ratio and relative risk. So what you can, except for Entresto, the number of people to treat to see a difference is actually comparable to that of GLP-1 receptor agonists and SGLT2 inhibitors. So heart failure decreased hospitalization for heart failure is actually very significant for SGLT2 inhibitors. So you can see it's about almost 50%, it's around 30 to 40% in this case. with and without history of previous hospitalization for heart failure. So it can also be used as a primary treatment to prevent hospitalization for heart failure. What about the renal composite endpoint? This is the reduction of renal endpoints, meaning renal deaths, end-stage renal disease, or doubling of serum creatinine. Again, there was almost 40% decrease in progression of renal disease. This includes decrease in proteinuria. And these are other tests that showed they consider other risk factor aside from atherosclerotic heart disease, and there was still decrease in hospitalization for heart failure. So these are the summary of all the cardiovascular outcome trial with the new anti-diabetic medication. Even new analogs of insulin has to go through this type of clinical trial. In terms of DPP-4 inhibitors, most of the studies showed neutral effect on cardiovascular outcome, except saxagliptin has been shown to increase the incidence of heart failure slightly. So things are not as good as everybody thinks. There's always a flip side, the side effects. So polyuria and nocturia is very common. Hypovolemia and hypotension, especially if you have a patient with heart failure who is already on diuretics. Lower urinary tract infection is almost 10%. Genital mycotic infection increase in both male and female. And then it's about 10% also. There's hypoglycemia only if you combine it with sulfonylurea or insulin treatment. Increase in LDL occur. Diabetic ketoacidosis, 70% of which are normoglycemic diabetic ketoacidosis. Therefore, it's important to remember that you do not decrease the insulin dose immediately when you put people on SGLT2 inhibitors, because it's the significant decrease in insulin dose that will precipitate DKA. The data collected so far showed 50% of the diabetic ketoacidosis occurred in misdiagnosed type 1, and 50% of the diabetic ketoacidosis occurs in type 2 diabetic patients, even without previous history of DKA. Bladder cancer has been reported with dapagliflozin. Bone fracture has been reported with canagliflozin. Remember, it has less specificity for SGLT2 receptor, and it will cross SGLT2-1 receptor, which is present in the intestine and muscle and other organs. Decreased bone mineral density has been reported with all of these treatments. Pyelonephritis is uncommon. Lower limb amputation is significant with canagliflozin. So if they have history of previous amputation, peripheral artery disease, or peripheral neuropathy, you have to think twice about putting patient on canagliflozin. So what is the GFR cutoff? This is based on what was the criteria when they conduct the cardiovascular outcome trial. For dapagliflozin and ertogliflozin, it's for GFR of over 60. for canagliflozin and empagliflozin, GFR above 45. Now, canagliflozin is being investigated for GFR between 30 to 45 at present. Again, you have to counsel the patient about genital perineal hygiene, orthostatic hypotension. So I get more complaints if I start the patient on this drug during the summer months. You need to conduct regular food exams. You need to instruct the patient on symptoms of DKA and ask them to avoid excessive alcohol. On follow-up, you need to check the renal function, body weight, blood pressure. You need to ensure the adherence to other therapy and lifestyle changes that it should be done with diabetes. One of the most dreaded complications of SGLT2 inhibitors is Fournier's gangrene, in which you get a polymicrobial deep fascia infection of the scrotum that will spread very quickly within an hour. The progression of the fasciitis is 2 to 3 centimeters every hour. So with fatality rate of 20 to 30%, no matter what you do. So the characteristic is patients complain of erythema, swelling, cellulitis, pruritus, and they have fever, generalized genital pain progressing to pain that's out of proportion. If this happens, this is considered as a urologic emergency. So they have to do wide debridement. Sometimes, as I said, it can progress by the hour, and infection can go all the way up to the clavicular area, and you have to ask the urologist to clean it up. And reconstruction is a very complicated process because it's a deep-seated infection, and it has been reported now with the SGLT2 inhibitor, although it's uncommon. I have never ordered so many, ultrasound of the scrotum until this generation of drug came out. In general, for the GLP-1 receptor agonists, the more potent they are in lowering glucose, and in lowering body weight, it's correlated to more cardiovascular risk protection. For the mechanism by which GLP-1 receptor agonists act to decrease atherosclerotic heart disease, it is localized. GLP-1 receptor is localized to many areas of the brain, specifically the appetite center of the brain. It decreases body weight. This is different doses of semaglutide after 1 year of study. And for the middle dose that we usually use clinically, the weight loss is as much as 13.8%. It decreases systolic blood pressure by about 4 millimeter mercury. In animal study, it reverses plaque formation, decrease the size of the plaque, but not proven in human. In terms of renal outcome, semaglutide has been shown to increase natriuresis from the kidney. So the mechanism by which the cardiovascular risk reduction may occur because of decreased glycemia, decreased body weight, decreased blood pressure, and decrease in LDL. Whether it will reduce atherosclerotic burden is not proven in human, but it has been shown in ApoE1 mutant mice. So when you prescribe SGLT2 inhibitors, you have to consider the protection from major adverse cardiovascular events. It's very effective in decreasing weight and A1C, and you don't get a lot of hypoglycemia from it. You may get improved renal outcomes. On the other hand, you have to weigh the risk for genitourinary infection, hypotension, risk for DKA, risk for fracture, and risk for amputation. So, because of these newer generations of drugs, the algorithm recommended by the American Diabetes Association has changed significantly. Metformin and lifestyle changes is still the primary treatment for type 2 diabetes, but the next second line of treatment, you have to ask whether the patient has atherosclerotic heart disease or renal disease with or without these morbidities. If the patient has atherosclerotic heart disease, the second line of treatment will be the GLP-1 receptor agonist and SGLT2 inhibitor. If you are dealing with a patient with history of heart failure or coronary artery disease or CKD, you would prefer the SGLT2 inhibitor. If there's no history of atherosclerotic heart disease or coronary artery disease and hypoglycemia is a problem, it's recommended that you use DPP-4 inhibitor, GLP-1 receptor agonist, SGLT2 inhibitors, or thiazolidinedione. If weight is a consideration because your patient is obese, you have to consider SGLT1 receptor agonists and SGLT2 inhibitors. If cost is a major issue, which is really a major issue, you have to go back to sulfonylurea and thiazolidinedione. Let's talk about cost. Metformin will cost $2 to $4 a month. These are the actual costs of the medication. Your pharmacist may charge $80 to $100 a month. Okay. Sulfonylurea costs $4 to $15 a month. How much the DPP-4 inhibitor costs? $170 to $413 a month. SGLT2 inhibitor, the price used to be half. It's about 200 something. Then all this cardiovascular outcome trial came out and they doubled the price. Now it's $257 to $448 a month. What about the GLP-1 receptor agonist? It's $634 to $835 a month. What happened to insulin? In 1923, Frederick Banting and Charles Best won the Nobel Prize for discovery of insulin. They decided to give away the patent for free because they wanted insulin to be available to diabetics at no charge. When Banting and Best turned over the patent to Eli Lilly for production, they agreed to receive only $1 each in compensation. Since then, drug companies have monopolized the insulin market and now charge diabetics at least $500 per month to survive. So, in summary, Several large randomized controlled trials indicate that two classes of glucose-lowering medications, the SGLT2 inhibitors and GLP-1 receptor agonists, confer significant cardiovascular benefits, including reduction in hospitalization for heart failure, progression of diabetic kidney disease, atherosclerotic cardiovascular event, and some cardiovascular death. The cardiovascular benefits of these drugs appear to be independent of its ability to decrease A1C. These findings did trigger a fundamental paradigm shift in the management of type 2 diabetes, wherein the focus is no longer solely in decreasing hemoglobin A1C, but also looking at the comorbid complications of diabetes. What the unanswered question is, should all diabetic patients get this type of medication? Some of the younger type 1 diabetics have low risk for cardiovascular disease when they're young, and the economic sustainability of these drugs and their use in everyday clinical practice. And also, all of this, FDA required only 18 months of study, so most of them are 2 to 3 years study. We really never know the long-term effect of medications until they have been used for years and years. Thank you for paying attention. So now, who are prescribing this drug? Most of the diabetics are being seen by the internists. So this yellow chart are the internal medicine people. The endocrinologists consist a small population of physicians, but they're also prescribing this drug. These are by the quarters. And the cardiologists, not so much. And I think it's going to be part of the cardiologist armamentarium, except I have to remind you, you have to look at the A1C, you have to look at the GFR, you need to look at the look for peripheral vascular disease, etc. And be aware that you will get calls for recurrent UTI, recurrent vaginal candidiasis, which could be very severe at times. Thank you for your attention. Any questions? Yes, they did modify the amino acid. Most of them are 2 amino acid substitution to prevent the action of dipeptidyl peptidase. Yeah, to prevent the degradation in order to be once a week injection instead of daily injection. The initial drug, Byetta, was twice a day injection. Victoza become once a day injection. Now all of this new generation are once a week injection. And in addition to changing the amino acid to prevent the rapid degradation, they also conjugate it to free fatty acid that binds to albumin, so it's slowly released. Oh, yes. Right. Yes, you're stimulating the pancreas beta cells all the time. Even though it's supposed to be specific to the beta cell, you don't know what will happen. There's higher incidence of pancreatitis, and also whether pancreas cancer will be an issue 20 to 30 years from now is an unresolved question.
My understanding is that the SGLT2 inhibitors heart failure even in diabetics.
Yes.
What is the mechanism? Is it
Okay.
Are they acting like a diuretic?
It's essentially
Much more involved.
It's essentially acting like a diuretic. That's why I went through the mechanism that it's for when they block the SGLT2 receptor, one molecule of glucose is lost, equal amount of sodium is lost. So there is, loss of sodium at the same time. As I said, there's 300 to 500 ml decrease in blood volume. And that's essentially what it is. That's how they get, decreased congestive heart failure, etc. Remember, Lasix, furosemide, and hydrochlorothiazide has never, even though it's used traditionally for congestive heart failure, it's instinctive, they're swollen, you need to get some volume out, has never been shown to prolong life or decrease hospitalization. So, but then hydrochlorothiazide and furosemide has very short half-life. The half-life of SGLT2 inhibitors is 13 hours. So that's the reason that it may have advantage over diuretics. About 40% of the patients enrolled in this SGLT2 inhibitor study are taking diuretics. Yes. So you did mention that if they do not have diabetes, what happens if you use SGLT2 inhibitors? They also do get some amount of glucosuria, but not as much as diabetic. It does not induce hypoglycemia because the pancreas will react to the lower glucose and produce more glucagon. So it could potentially be used as a diuretic, except for the fact that 1/3 of the US population are already pre-diabetic, so most of them will still increase the glucosuria with the concurrent complications of UTI mycotic infection. No? Good. Thank you. Amen. And the GLP-1 receptor agonist has been shown to decrease liver fat content in human. Thank you. Thank you. Thank you. Okay. I hope somebody. I